Now it's a pleasure to invite our next speaker, who is no other than Dr. Sanjay Agarwal, sir. I think we do not need to introduce him. He is our mentor. We are having his idea because he is here, and we will hear him about evolution from anti-diabetic to cardio-renal protection from Dr. Sanjay Agarwal, sir. Over to you, sir.
Sorry. Thank you very much, Dr. Archana, for this kind introduction. And I'm going to straight away get into the talk on which I'm going to be speaking about. And that's the evolution from anti-diabetic to cardio-renal protection. And it's a very interesting talk. What started out as an anti-diabetic medication has transcended now boundaries to tell us that a particular drug which was used for glucose lowering has now got benefits in terms of improvements of cardiac function and renal function. And we keep discovering new aspects of this drug every day with newer sort of trials that are coming into force. But today I'm going to really focus my attention on talking about the role of SGLT2 inhibitors in cardiorenal protection. Now, just as a background, I want you to understand that in a typical Indian patient, what is the kind of a patient who comes to us in a clinical practice? We see that 57% of them have abdominal obesity, 71% of them have concomitant hypertension. When you have a patient with diabetes, an Indian patient with diabetes, there's a twofold increase in the cardiovascular risk or cardiovascular events, and there could be about 30 to 70% risk of developing some kind of a kidney problem. Across the board, if you look at the CKD registry of India, 30% of our patients with diabetes end up with full-blown diabetic nephropathy. Now, we do understand while there is a common risk factors like smoking, obesity, hypertension, dyslipidemia, and various genetic and acquired risk factors, which are common for development of chronic kidney disease or advanced heart disease, the point of intervention has to be much earlier at the time that we feel that, patient has got just an albuminuria or probably at a risk for developing kidney disease. Similarly, if you look at all the cardiovascular risk factors, we need to intervene at that point of time aggressively rather than have somebody who comes to us with advanced cardiac disease. If you look at the hospitalization rates for heart failure and kidney disease burden, and you're looking at your stratification between patients who have diabetes and who don't have diabetes, you find there's almost an equal amounts who end up, whether they have diabetes or not, with heart failure or chronic kidney disease. So presence of heart failure or chronic kidney disease in patients with diabetes is rather not uncommon. And we need to make sure that all our patients who come, we are aggressively screening them for an early onset of either kidney disease or presence of cardiovascular disease. Some of the reasons why probably cardiovascular risk is high in diabetes, because majority of our patients end up having hypertension or dyslipidemia, which puts them at a higher risk. And we know that against the background that our average A1C is close to 9%, this is a perfect triad for developing a higher risk for heart attack over the next 10 years, increased risk of heart failure, and increased risk of nephropathy, which may end up with end-stage kidney disease and dialysis. This is important because we do realize that if you look at all the different cardiovascular events that happen in diabetes, and this is not really gender specific, we find that amongst all the cardiovascular events, heart failure is one of the most common problems that patients end up in the hospital with, other than acute coronary syndrome, dysrhythmias, ischemic strokes, or hemorrhagic strokes. This was from the Paradigm Heart Failure Study. And what they did show in a patient population of about 8,000 odd patients who had a heart failure with reduced ejection fraction, that almost about 25% of the patients had pre-diabetes. There were 13% who had undiagnosed diabetes. 36% of the patients had diagnosed diabetes, and only about a quarter patients were normal. So really, it's not uncommon that you tend to have some form of diabetes in majority of the patients who come to our hospital with a heart failure with reduced ejection fraction. And even more interesting is the fact is the percentage of unknown presence of preserved or reduced ejection fraction in patients with type 2 diabetes. And this study looked at almost about 580 individuals who were of more than or equal to 60 years of age. And if you look at the various sub-analysis according to age group, you do find that presence of preserved ejection fraction has a higher preponderance as compared to reduced ejection fraction. And that stands to reason because patients who have a reduced ejection fraction would tend to come to us much earlier with symptoms and evidence of cardiac disease. But very often patients who have got preserved ejection fraction, heart failure with preserved ejection fraction, get masked out because they tend to simulate many other conditions. The patients may come to us with only breathlessness in absence of any other cardiac symptoms, and they get often misinterpreted with either a respiratory problem or some other reason, and they tend to get diagnosed much later. So a lot of hospitalization that happens, we tend to miss out heart failure with preserved ejection fraction unless we are vigilant to diagnose them. How does really SGLT2 inhibitors benefit in the subsets of patients? We know that SGLT2 inhibitors causes weight reduction, blood pressure reduction. It's a very safe drug to use because it causes less hypoglycemia. We have proven trials for cardiovascular safety and heart failure treatment. And now we also have robust trials which demonstrate renal safety and prevention of progression to chronic kidney disease. Now, these are some of the ways that they tend to have an effect. If you look at the cardiac effects, you can see the entire gamut of effects that they tend to have to improve the cardiovascular events. So reduction in blood pressure, improved endothelial function, weight loss, and reduced visceral fat, reduction in albumin excretion rates, reduction in uric acid, and improvement in the lipid profile. The kidney effects stem from the fact that it causes reduction in renal perfusion pressures, reduction in glucotoxicity and its effect on tubular cells and tubular hypertrophy, suppression of the tubular-glomerular feedbacks, reductions in urinary albumin excretion rates, uric acid excretion, which increases less nephrolithiasis, and suppression of the RAS aldosterone systems. So just as you have an octet for pathophysiology of diabetes, Ralph DeFranco has now proposed an octet for the occurrences of chronic kidney disease, and he's now shown that SGLT2 inhibitors tend to have effect on most of the pathways which cause chronic kidney disease. Now, the relationship of occurrences of kidney and heart in type 2 diabetes are bidirectional and pathophysiological. And you can read in this busy slide the way the effect occurs. So for a heart, it may cause an increase in preload and afterload. It may cause an increase in cardiovascular stress and decrease in cardiac efficiency. There could be cardiorenal complications by increased incidences of cardiomyopathy, which may present to us with heart failure or a diabetic kidney disease. And the circulatory system may be volume expanded, vasoconstricted, and there could be an increase in systolic pressures. SGLT2 inhibitors tend to have an effect on all these effects to improve them. And in that way, they tend to improve the outcomes when a patient comes to us with heart failure and kidney disease. These are some of the potential ways by which SGLT2 inhibition improves renal outcomes, and it causes a reduction in the glomerular pressure, causing a stabilization of eGFRs. There could be neurohumoral improvement, so there could be a reduction in blood pressure as a consequence. There could be alterations of the inflammation and fibrosis, which sort of prevents tubular glomerular injury and reduces the albuminuria. And there could be a decreased renal workload and hypoxia, which reduces the renal ischemic injury, and it causes an increase in the hemoglobin and the hematocrit. And this ultimately leads to a more preserved renal function. So if you look at the guidelines now, if you look at the AD and the ACE guidelines now, they have now become more specific that after metformin and after lifestyle and metformin, you look at the patient phenotype, and if ASCVD predominates or heart failure predominates or CKD predominates, or where the patient has got a high risk factors, then one of the mechanism by which you treat them is by use of SGLT2 inhibitors, which may cause a reduction in heart failure and improvement in the renal status. I'm going to really talk a little bit more about the role of SGLT2 inhibitors in this bidirectional relationship of heart failure and chronic kidney disease. And we know that in heart failure with reduced ejection fraction, if you use SGLT2 inhibitors, it can cause a reduction in cardiovascular death. It can reduce hospitalizations for heart failure, improve the symptom burden, and all with a favorable safety profile. Similarly, if you look at the effect on preserved ejection fraction, because this was one gray area where we didn't really have any good enough treatment. And always the speculation was that will SGLT2 inhibitors be as effective in heart failure with preserved ejection fraction? And now we've got the results of the Emperor Preserve trial, which has shown a significant improvement as much as patients with reduced ejection fraction. And the reason is that the left ventricular diastolic dysfunction is improved, more rapidly growing type of heart failure, which is why now we're seeing more and more preserved ejection fraction. And that's really the unmet need. One of the reasons why probably the need for getting a robust drug for heart failure with preserved ejection fraction is because this class of heart failure is more common in elderly, and it is responsible for almost about 40% of heart failure in the adult populations. And many patients may have systolic and diastolic dysfunction. So that's why agent like SGLT2 inhibitors would tend to have a benefit. And with now evidence mounting up, we know that SGLT2 as a class can be used with both preserved and reduced ejection fractions. Now the entire guidelines for management of heart failure has been rewritten from 2020 onwards. So there is an increasing role of ARNIs, beta blockers, mineralocorticoid receptor antagonists, and of course, SGLT2 inhibitors. So what was a conventional way of treating patients with heart failure has seen a sea change with the introduction of all these newer agents, which has improved outcomes and survival of patients with heart failure. These are the mechanisms by which they work through the pathways of glucose excretion, neurohumoral activation, anti-inflammation, and altered myocardial energetics. And there's a whole bit of benefits of ketone hypothesis, which I'm not really going to get into this as an alternate fuel, which is more beneficial in terms of outcomes where heart failure is concerned. Now, if you look at the data, which has evolved over time, and the data has actually looked at the different stages of heart failure and kidney disease, patients with and without diabetes. So while in the preclinical stage, you've got now data that is coming from the Canvas program, Credence, DAPA, CKD, Declare, TIMI, EMPA-REG, Vertis CV, and SCORE trials. And these have also looked at in presence of clinical stage of the disease. But where there is a detectable cardiac involvement, the benefits have been proven through the DAPA-HF, deliver heart failure with preserved ejection fraction. These are ongoing trials. The Emperor Preserved results have just been released, Emperor Reduced, and the Solace WHF trials. And these are from the spectrum of normal ventricular function to end-stage heart failure. Now, I'm just going to give you a brief about the cardiovascular outcome trials that have been shown to have benefits with SGLT2 inhibitors. So why have we really got the CVOT trials? So prior to the rosiglitazone story, we always kind of looked at that. We never looked at basically cardiovascular safety. After the rosiglitazone story, we are now looking at the FDA mandated that if a new agent is introduced, then is it cardiovascular safe? So we have to show a non-inferiority placebo, and all agents that are introduced have to go through a safety trials. But after the LEADER trial, there has been an increasing growing need to see that any molecule that is introduced now, does it have an additional benefit in terms of superiority rather than only safety in terms of either 3-point MACE or a 4-point MACE, as well as its effect on hospitalization for heart failure. So these are some of the trials that have been published for cardiovascular and renal outcomes. The EMPA-REG, CANVAS-R, DECLARE-TIMI, CREDENCE, and the DAPA heart failure. These are more of a cardiovascular-based trials. And you can see in the data over here that they have all looked at mean duration of diabetes, which have been long. The baseline A1Cs that you can see over here have all been close to about 8%. And they've looked at the MACE outcomes, hospitalization for heart failure, CV deaths, non-fatal and fatal MIs, strokes, all-cause mortality, hospitalization for heart failure, and renal composite endpoints. While you see that there is a modest improvement in terms of MACE outcomes, the data has been more strong in terms of reduction in hospitalization and events for heart failure or renal composite endpoints. And I'm going to dwell on this a little more in the later slides that are going to come over here. Just a bit of comparison between DECLARE-TIMI 58, which was done with dapagliflozin, and EMPA-REG with empagliflozin. And here you're seeing the trials in type 2 diabetes with or without heart failure. And you can see clearly that there is more or less an equal benefit, with the EMPA-REG having a slightly more benefit in terms of cardiovascular death or with all randomized patients, or cardiovascular death with patients with prior myocardial infarction. But when it comes to outcomes for CV death and hospitalization for heart failure, first hospitalization for heart failure and renal composite outcomes, they're very more or less similar in terms of improvement. And these were all, the p-values were statistically significant. But what about trials in heart failure with reduced ejection fraction with or without diabetes? And these were studied in the DAPA-HF and the EMPEROR-reduced trials with DAPA and empagliflozin. And you can clearly see the benefit, which are more or less comparable when it comes to cardiovascular death or hospitalization for heart failure, first hospitalization for heart failure, renal composite endpoints, and cardiovascular death in all randomized patients. I'm just going to go a little further in saying that let's look at the sub-analysis. And the first thing that you look at is the all-cause mortality. And you can see the DAPA-HF has shown a little better benefit with more clearer p-value significance as compared to EMPEROR-reduced. When it comes to cardiovascular death, again, the DAPA-HF has shown a better results, almost to the tune of about 18% reduction versus 8% reduction with the EMPEROR-reduced. First hospitalization for heart failure, there has been almost a very similar 25% reduction in hospitalization for heart failure or cardiovascular deaths. But if you look at the further, that first hospitalization for heart failure has been very similar. What about first kidney outcome? There has been a slightly better results with the EMPEROR-reduced in comparison to DAPA-HF. And if you look at the all first or recurrent hospitalization for heart failure, cardiovascular death, they're more or less been very similar between the EMPEROR-reduced or the DAPA-HF study. Now here they looked at according to the diabetes status. And this was very important because while we have seen that the benefits have been very clear in patients with diabetes, they've gone a step ahead to say that are these results extrapolatable in patients who do not have diabetes? And here you can see patients with diabetes and without diabetes, and you can see that the results are very similar in terms of improvement with sort of hospitalization for heart failure or cardiovascular deaths. So now the entire algorithm for treatment has changed for heart failure, that not only patients with diabetes, but even patients who do not have diabetes has shown a great improvement with SGLT2 inhibitors. And these have been equally shown with dapagliflozin and empagliflozin. So right from the lab of diabetologists, it's gone into the realm of cardiologists who now are using this molecule more and more in treatments of heart failure. If you look at gender-wise, they have shown that both men and women are equally benefited with SGLT2 inhibitors, and this data comes from both the DAPA-HF and the EMPEROR-reduced study. What about patients who've got a background therapy with ARNI? So will addition of SGLT2 inhibitors have beneficial value? And here you can see that they have compared patients who are receiving ARNI versus patients who were not receiving ARNI, and they've shown a clear benefit that SGLT2 inhibitors introduction has better benefits and with little side effects in terms of hypertension or other effects. And this has been shown with both the DAPA-HF and the Emperor-reduced, with a little more clearer benefit with the Emperor-reduced, with the empagliflozin than dapagliflozin. Again, if you look at the age subgroup analysis, you find that there is a better evidence of improvement in patients who are more elderly, and they've looked at patients all the way from 55 years, actually less than 55 years, all the way up to 75 years, and patients more than 55 years of age, all the way up to 75, have shown a clear benefit with SGLT2 inhibitors. Just in interest of time, I'm going to go a little faster. They have again seen patients who had a GFR less than 60 versus more than or equal to 60, and the benefits have been equally seen. These were all according to obesity, according to the BMI, we have seen the benefits. And if you now have to really look at this entire on a priority basis, from the clinician's perspective, what are the endpoints that you're really looking at? And if you're looking at MACE prevention, probably equally good, but probably GLP-1 has a slightly better edge as compared to SGLT2. But when it comes to heart failure prevention, then SGLT2 class is better. Weight loss is better achieved with GLP-1 as compared to SGLT2. And if you have to look at the endpoint of renal disease progression, then SGLT2 inhibitors as a class is better. These are some of the key renal outcome trials. That's the DAPA-CKD, Credence, EMPA-Kidney, and the FIDALGO-DKD. There have been clear benefits in outcomes where primary and secondary outcomes are concerned, renal-specific composite outcomes, need for dialysis, death from cardiovascular cause, and kidney disease. There's been very clear benefits with the canagliflozin and the Credence. And if you look at the DAPA-CKD, then all primary and secondary outcomes have been benefited with dapagliflozin in the DAPA-CKD study. And I'm just going to go through a little fast in interest of time. So they've looked at patients who are albuminuric versus not albuminuric according to GFR class. And you can see here that there's a clear benefit with the introduction of dapagliflozin. If I have to just summarize the DAPA-CKD study, there is a 39% relative risk reduction for the primary composite endpoints, which is more than or equal to 50% sustained decline in the eGFR, end-stage kidney disease, renal or cardiovascular death. 44% relative risk reduction for renal composite outcomes. That's more than or equal to 50% sustained decline in eGFR, end-stage kidney disease or renal death. 29% relative risk reduction for the composite CV death or hospitalization for heart failure, and 31% relative risk reduction for all-cause mortality. So in summary, I just want to add that management of type 2 diabetes is all about not just lowering of A1C, but we also need to keep in mind the safety, that's hypoglycemia prevention and weight gain. And now we are moving a step further in terms of cardiovascular and renal protection. So while we have the conventional agents which have been looked at very clearly, the role of SGLT2 and GLP-1 analogs have now expanded in terms of improvement in all these endpoints. And the major thing is still now the deterrent to use these agents have been the cost. With the dapagliflozin becoming generic, it's now brought the use of SGLT2 inhibitors and dapagliflozin more within the purview of clinicians to offer better treatment profiles for their patients. So if we have to rewrite today the algorithms, then we have to look at what are we trying to achieve in our respective patients. Is it weight loss? Is it just ASCVD with heart failure or without heart failure? Are we looking at prevention of kidney disease? Or are we looking at safety from the elderly population? And we have clear choices that have been outlined. And you either have to use SGLT2 inhibitors or GLP-1 analogs. But given the safety, the cost, and the improvements, SGLT2 inhibitors are a class that have come to stay. Thank you very much for your patient listening.
Thank you so much, sir. I think this talk was by itself very, very, complete by itself. And we have seen the journey of SGLT2 inhibitors in people with diabetes for cardiorenal protection. Sir, I had just one question. Can you please share your experiences with people without diabetes, the use of SGLT2 inhibitors in your practice?
Yeah, so as I pointed out to you, there have been clear benefits that have been demonstrated, that there have been equal benefits seen, and I had a slide to show that. that they have looked at the effect of SGLT2 inhibitors and dapagliflozin, DAPA-HF study particularly, and they've seen that the benefits are equally seen whether the patient had diabetes or not diabetes. And this was a surprise because when the DAPA-HF study was started out, they had only the patients with diabetes in mind, but then they have expanded the role to include patients without diabetes, and they have shown that the benefits are there, irrespective whether the patient has diabetes or not diabetes.
So, but any
In all the
incidences of
endpoints.
DKA, any incidences of DKA or
See,
fluid-related
euglycemic
issues?
ketoacidosis is a condition which we actually see very little about. And that should not prevent us from using SGLT2 inhibitors as a class of agents. There are clear sort of, if you look at in terms of percentages, none of us have seen really euglycemic ketoacidosis as common, but the benefits outweigh the risk. So we should clearly go ahead and use. Yeah, keep in mind the red flag that euglycemic ketoacidosis is one of the known complications, and we have to be vigilant about it.
Thank you so much, sir. Thank you. And with your permission, I think we will close this session.
Thank you. Thank you, Archana.
Thank you.